Good afternoon, everybody. Good afternoon to the people who have joined here, and good afternoon to all the people who are online on YouTube and other online channels. From the Department of Urology, we are going to present an interesting case where a very young patient had undergone a relatively simple, straightforward, uneventful surgery, but her post-op course was like a roller coaster ride. And all this was basically because of relatively not so uh, common, not so uncommon an infection. And what one infection has done to the whole world in the last 2 years, we all are witnessing. And in this case presentation, what multiple infections did to one particular young patient in the post-op course, that is what would be discussed. The case would be presented by Dr. Ankit Sachan, our senior resident, and then Dr. Adil from infectious diseases and Dr. Jasper from the critical care team in the AB8 ICU will make their parts of the presentation. The final discussion would be by Dr. Rishi Nair, consultant in our Department of Urology, and Dr. Arvind, consultant in the Department of Infectious Disease. Thank you. So now I invite Dr. Ankit Sachan.
Thank you, sir. Good afternoon, everybody. So the topic of today's CCR is surviving the ordeal, viral, bacterial, and fungal onslaught on not so maime surgery, presented from Department of Urology. So a 32-year-old female presented to us with a complaint of right side flank pain from past 10 months, which was moderate in intensity and dull aching. There was no history of hematuria, lithuria, or any lower urinary tract symptoms. She had history of hypothyroidism, but no other comorbidity associated. Her systemic examination was perfectly normal, and on further evaluation with ultrasound and CT scan was found to right kidney was moderate hydronephrotic with non-dilated ureter. He was further evaluated with IVP, and also the renal dynamic scan showed right side kidney with 42% functioning with obstructive pattern drainage. A pre-op culture was trialed, and a diagnosis of right side urinary uretropelvic junction obstruction was made. So the patient was taken up for surgery on 17th of September 2021, and right-sided robotic pyeloplasty was done. Intraoperatively, crossing vessels were present, and a standard Anderson-Heinz dismembered pyeloplasty was done. The ureter was spatulated, dismemberment was done, and transposition anterior to the crossing vessels was done, and following the anastomosis. So there was no intraoperative complication during the whole surgery, and the blood loss was less than 50 ml. Let me guide you through the usual post-op course of a robotic pyeloplasty. The Foley removal is done mostly on the post-op day 1, followed by drain removal on post-op day 2, and most of the patients get discharged either on post-op day 2 or 3. But let's discuss the post-op course of this patient. On post-op day 1, the patient had high-grade fever of 102.4 knot Fahrenheit, and also had complaints of nausea and vomiting and gastritis-like features. Her drain output was nil. The extra QOB showed the stent was in situ. We started to think it's as a post-op fever. On the post-op day 2, the symptoms and the fever continued along with the pain in the right upper abdomen, but the ultrasound abdomen still showed no collection. There were intermittent fever spikes as shown. On post-op day 2, on the thorough fever workup with a decreasing platelet count, the NS dengue antigen was found to be positive, along with deranged LFT, leukopenia, and decreasing platelet counts. Her ALT and AST levels were more than 10 times raised. The drain output started increasing on post-op day 3, 4, and 5, but on the drain creatinine was normal, so there was no urine leak. Infectious medicine consultation was sought and was advised for hydration and antibiotic. A platelet count gradually decreased from 1,12,000 to another value of 54,000 on post-op day 7. We transfused the patient with 4 RDP and 1 SGP. On post-op day 6, there was persistence of fever with nausea and vomiting. The new finding was the patient started having mild hematuria and falling hemoglobin, and the drain output was 200 ml. On ultrasound abdomen, there was hydronephrosis along with clots in the PCS. But on post-op, after the transfusion of the platelets, also her TLC counts, which was initially leukopenic, raised, and came to the normal level. Also, the ALT and AST levels also starting to become normal. Post of day 7, so the fever was still continuing, but the hematuria settled after the platelet transfusion, and also the drain output was minimal. So the drain was removed on post of day 8. On the post of day 8, the leukopenia, which became normal, again the leukocytosis started to happen. On post of day 9, the patient had hypotension with raised lactate levels, and she was started on inotropes, and the antibiotic was upgraded to meropenem. The culture sent of post of day 10. One thing I forgot to tell, that the cultures sent in the post of day 3 came out to be sterile on post of day 5, both the urine and the blood cultures. On post of day 10, the culture sent came out to be more than 3 gram negative bacteria in the urine culture, and Acinetobacter pyti was found in the blood culture. On post of day 10, the patient was finally shifted to the AB8 ICU in view of hemodynamic instability, also because of the respiratory distress. Post of day 11, the blood culture showed the E. coli sensitive to the colistin, and the urine culture showed E. coli, which was sensitive to nitrofurantoin and phosphomycin. The further course in the ICU will be presented by my colleague from the critical care medicine.
Good afternoon, everyone. So, we received the patient on the post of day 11 in AB8 ICU, and the initial assessment of the patient, we found that the vitals where she was febrile, she was tachycardic, she was having a lowish blood pressure, which was maintained with the NORAD infusion. Her peripheries were warm, suggesting it could be a septic shock, and she was also having significant tachypnea, using her accessory muscles of respiration, and her saturation was 100% on 2 liters of oxygen. GCS was normal. She did not have any pallor-icterus cyanosis or any edema at this point. Continuing the further assessment in the ICU with the point of care ultrasound, we found that on the right side, she had a 2.1 centimeter pleural effusion, and she was also noted to have underlying consolidation, which was evidenced by a dynamic air bronchogram, which was noted. And she also had dependent B lines on both left lung and right lung. Her echo showed her cardiac function was normal, and her volume assessment showed that she was not hypovolemic. Her acid blood gas which was done showed that she was having a metabolic acidosis with the respiratory compensation, and her lactate at this point was 4.9. So at this point, the clinical diagnosis that we considered was the symptoms that she had, and her presentation was she was having a shock which was warm, probably a septic shock, and the focus, when we searched for it, she had a right-sided pleural effusion along with some basal consolidation, and she was having a recent history of probable dengue infection, and she has a background of a robotic surgery which was done, a robotic pyeloplasty which was done. So at this point, the differentials that we considered were either a possible urosepsis or a severe dengue with shock or a hospital-acquired pneumonia. She was having an SIRS criteria score of 3 out of 4, and a SOFA score at this point was 4. And the investigations during the ICU at the day of admission, she was having a lowish hemoglobin count. Her TLC had again, we saw the trend had dropped, come up, and again it had started dropping. Renal functions were normal. Bilirubin at this point was normal, and the ALT AST had kind of normalized. Procal, which was done during ICU admission, was 11.7, and her CRP both were significantly elevated. So the management in the ICU at admission, since she was in shock, we had upgraded the antibiotics. Antibiotics were upgraded to meropenem and teicoplanin, and levofloxacin was added as a second gram-negative agent. Ultrasound abdomen, which had already identified the hematoma in the pelvic calyceal system, and the same features were found during the ICU stay also, and there was moderate hydronephrosis. ECT abdomen was also done, which showed the same finding, hematoma in the pelvic calyceal system, and there was no contrast extravasation suggesting an active bleed. Supportive care wise, since she was significantly tachypnic and she was having increased work of breathing, she was started on high flow nasal cannula to support her breathing, and she was given ultrasound guided fluid therapy along with the vasopressor infusion. She was given GI ulcer prophylaxis with pantoprazole. She was on DVT prophylaxis by sequential compression devices. Fever management was done with paracetamol. Nutrition, she was given IV fluids, and as much as she could tolerate orally. She was having significant nausea and vomiting and she was having anemia, which was supported with packed red blood cell transfusion. Post in the ICU, initial 2 days, she continued to have persistent fever spikes. She had some transient decrease in inotrope requirement, but the intensity of the fever or SIRS features did not improve. Just having persistent tachycardia and tachypnea. We gave her good hydration on the initial day, and then she was maintained equivalently without letting her become positive or negative. And a diagnostic pleural tapping was done for the pleural effusion, which was there, which was suggestive of an exudative effusion. There were no features to suggest it being an empyema. Counts again started going down. Lactates from 4.9 started coming to 3.6. Renal functions were normal. Further course in the ICU, she continued to have persistent high-grade fever with the mild increase in vasopressor requirement, increase in bilirubin. Overall SOFA score had started going up to 6. At this point, injection colistin was added empirically because she was not responding to the initial antibiotics, and she was overall behaving like a septic shock. And this time we noticed that her bilirubin had gone up. Procal was persistently high. And then we got the urine culture and blood culture report, which both grew E. coli, which was sensitive only to colistin. And the urine culture E. coli also had sensitivity to nitrofurantoin and fosfomycin. So at this point, nitrofurantoin and oral fosfomycin was added. Repeat ultrasound showed similar findings. By day 7, day 8, her shock had resolved and her respiratory distress had come down. Fever spike intensity had also come down, but she still continued to remain febrile. And on day 8, she was shifted out of the ICU. At this point, overall picture looked like probably the focus of infection is in the kidney, and surgical intervention was being considered, and they were weighing whether the kidney could be preserved or not.
So, in a brief, in the ICU course, the patient was managed with high flow nasal cannula, inotropes, antibiotics with meropenem, teicoplanin, and colistin with a waxing and waning course. He had bilateral lung consolidation and patch present along with the bilateral mild pleural effusion. He continued to have fever spikes, and a CECT was done to look for any other source for any urinoma or the presence of the status of the right kidney. So the CACT abdomen done on post-op day 14, that is 1st of October, showed moderate hydronephrosis in the right kidney with poor nephrographic enhancement. The PCS was distended with hyperdense contents, likely the blood clots. There was no excretion of the contrast in the PCS. And at this time, we were in a dilemma whether to go with a life-saving nephrectomy. But we decided to defer the life-saving nephrectomy as the renal function in the case of acute sepsis and emphysematous pyelonephritis and septic condition is not the contrast uptake is not the true representative of the renal function. Also, the patient was improving on the conservative management. On the post of day 18, the patient was shifted back to the ward. But after 2 days, she again started having fever episodes. And ultrasound was done, which was suggestive of moderate left hydronephrosis with hyperglycemic contents within the PCS, likely blood clot. Now, at this point of time, we thought of going with a percutaneous nephrostomy. There were clots in the PCS, and so PCS might help in the drainage of the infection. On post-op day 25, the right side PCN was placed, which only had a mild purulent output less than 30 ml per day, and so NCCT KOB was repeated to look for any collection or also the position of the PCN. So it showed gross hydronephrosis with dilated pelvis with PCN was in situ and there was no other abdominal correction or urinoma. The PCN culture which was sent on 13th came out to be the trichosporin HI, and the urine culture on 16th came out to be Candida tropicalis. So our patient has suffered the onslaught of first the viral infection, followed by the bacterial infection, and now was presenting in the on the onslaught of the fungal sepsis and the fungal infection. On 14th, she was started on injection voriconazole, followed by oral voriconazole on the basis of the medicine consult. The patient showed a dramatic response to voriconazole and became afebrile after 2 days, that is 16th of October 2021. The PCN output gradually increased to around 1.5 liters per day, draining clear urine. And the patient was finally discharged on 24th of October on post-op day 37 with right PCN in situ. Now talking about the follow-up course, the patient was afebrile in the post-op course and was voiding well. Antifungal was stopped and followed by a CCT was done. This repeat CCT on 12th of December showed mild perinephric standing, normal functioning right kidney with contrast excision in the delayed phase. So the DJ stent removal was done after 13 weeks of the surgery, that is on 24th of December, and the PCN was clamped at 14 weeks and removed under the antifungal cover after 15 weeks, that is 5th of January 2022. The patient is presently having no other complaints. Now, our colleague from Dr. Adil from infectious medicine will discuss the various diagnoses at various point of time.
Good afternoon, everyone. So I'll be discussing the part where the patient was treated for bacterial, viral, and fungal infections. So our side was initially consulted for persistent fever in the post-operative period. So we were consulted on day 3, POD day 3. So the patient presented, patient was admitted in the peak of dengue season. So initial preliminary workup was suggested, and fortunately and unfortunately, the dengue NS1 antigen was positive on POD day 3. So the cornerstone of management for dengue fever is supportive care along with clinical and lab monitoring. So we suggested the same to the treating team. But the paramount philosophy of any infection is behavior under treatment as well as observation under treatment. So if a patient is not behaving as it should on your observation and treatment, then you will have to look for other etiologies for the same complaint. So when you see a patient with dengue fever, so the behavior of the disease is like that. It will progress through three different phases. You will have a febrile phase, then the fever will respond, and the patient will go into the critical phase. Few percentage of patients will go into the critical phase. Patients will be in critical phase for 2 to 3 days, then they will come out and be in the convalescent phase. So here what happened that despite our supportive care, patient's fever didn't subside despite 3 to 4 days of observation. Usually the febrile phase will last for max of 5 days, or occasionally a patient will have a fever for 7 days. But here in case patient was having persistent fever spikes despite being NS1 positive 5 days earlier. So that is at the time a repeat consult was sought from our side. So when we saw the patient at that time, she was hemodynamic unstable, and then at that time she was shifted to AB at ICU. So at that point of time, the differential was changed from dengue shock syndrome, and the first differential was kept as sepsis with septic shock, because the dengue was not behaving as it should under our observation and treatment. If you see here, this is the chart which you should remember when seeing a patient with dengue. So you will have a febrile phase. Once the fever comes down, then the patient will go into critical phase, and there is the time point where the patient may go into shock or will have bleeding. And there is one more point which is important regarding the urological point of view here. The conventional threshold for administering platelets is somewhere around 10 to 20,000, but here we have to be more pragmatic. The patient has undergone surgery, there are clots in the pieces, so you cannot use the conventional threshold of 10,000. So you have to be a little pragmatic, and you have to adjust the threshold to a slightly higher level of platelet count. This is what the team had done. They had given platelets at a slightly higher platelet count of 30-40,000. So because you cannot be because you cannot be very rigid with respect to the cutoff of platelet count transfusion. So given this behavior of the fever, so dengue was behaving as it should, platelet count was improving, leukopenia was improving, AST ALT was coming down. So dengue was behaving as it should, but patient was continuing to have fever along with new hemodynamic instability. So at that time, sepsis with septic shock was entertained into the differential diagnosis. So we advised initially empirically upgrading the antibiotics, continuing fluid and ionotropic support, which was given by the critical care team, and also we advised workup for source of infection with urine, routine microscope, urine culture sensitivity, blood culture sensitivity, procalcitonin, as well as chest X-ray, plus minus CT chest abdomen. So after the patient was shifted to ICU, the evaluation revealed that procalcitonin was elevated. Her initial blood culture sensitivity was suggestive of Acinetobacter, which was fortunately sensitive to piperacillin as well as cefepozin sulbactam. A second blood culture sensitivity revealed that E. coli and the same organism was also grown from urine. So we had two culture reports, one from urine and one from blood, same organism, same susceptibility. And we have two antibiotics which have excellent urinary penetration. One is colistin, one is fosfomycin. So we advised for upgradation of antibiotics based on these culture reports. So meropenem and teicoplanin were continued because the patient was in hypotension, and on top of this, colistin and fosfomycin as added. So as you saw that patient had a quick response to the therapy in terms of hemodynamic stability as well as defervescence. So after the patient was shifted to the ward, then fever had again recurred. Now on the second evaluation, you can see that there was a fungal culture report from PCN fluid which had grown trichosporin acai, and there's a urine fungal culture report which had grown Candida tropicalis. So there's a dilemma. Trichosporin acai is a multi-drug resistant fungus. It won't respond to your fluconazole, amphotericin B. It has high MIC to amphotericin B even, and fluconazole won't respond. And you have Candida tropicalis, which response to echinocandins, but the level of echinocandins in urine is pretty low to treat Candida tropicalis. And you have to struck a balance which infection is more likely to account for this patient's fever and which infections are you going to treat by an antibiotic which will have prominent coverage against that organism and some amount of coverage for the second organism. So that drug is voriconazole. Voriconazole is still considered drug of choice for a trichosporin SI, but it's difficult to eradicate trichosporin SI if it is grown in a blood culture. Fortunately for this patient, blood culture sensitivity was sterile, so it was not an invasive infection by trichosporin SI. It was a limited infection to the renal parenchyma. That is why the patient had a good response to first IV followed by oral voriconazole. Otherwise, the mortality in best of the best centers with trichosporin invasive infection, it goes above 75 to 80% in best of the best centers. But here the infection was limited and the drug was initiated early. Once the culture report came, the patient had a good response to therapy. And it's very difficult to treat trichosporin SI. Let me remember you that amphotericin B, even if amphotericin B lab reports amphotericin B sensitive to trichosporin SI, the amphotericin B does not achieve enough concentration to kill the fungus. Even fluconazole, posaconazole, all the newer azoles, they don't achieve the same level to kill this fungus. It's highly resistant to all these available agents. So the patient got lucky that the infection was limited to renal parenchyma, and we had a drug which we could give IV as well as orally. That's why she had a good response probably to the therapy. Thank you.
So not the discussion part. Out of the systematic review and meta-analysis of 15 studies of the perioperative outcomes and the complications of the laparoscopic versus the robotic pyeloplasty, it was seen that there was no reports of the grade 4 or grade 5 complication. But our patient here had multi-organ dysfunction and received the ICU support, so landed into the grade 4B because of all these infections. Also, the available mortality and the morbidity data of the dengue hemorrhagic fever and the trichosporin shows that the dengue fever in the renal transplant patient, there was mortality of around 8.9% out of the 168 patients. A case series report of 6 GI surgical patients who developed dengue showed that there was out of them the 2 developed dengue in the post-op period and 1 even succumbed to the illness and showed a mortality rate of around 33.3%. The cancer-associated urinary tract infections due to trichosporin SI was studied, and among the 6 patients, the 4 were the females, as was the female, and all the patients were in indolent catheter with a mean duration of 18 days. All were resistant to the amphotericin B and ketoconazole and were sensitive to the voriconazole. And similarly, our patient also responded to the voriconazole. Trichosporin SI fungemia in a patient with a non-hematological malignancy case report in a patient who was operated for the radical cystectomy and the ileal reduced expired due to the fungal septicemia. Trichosporinosis in a tertiary care center, risk factors showed that the 30-day crude mortality rate was around 53% in the cancer patient. Luckily, our patient didn't have the trichosporin infection in the blood. So the take-home message is that we should have a high degree of suspicion for the dengue even in the post-op period, and early detection is necessary to guide the fluid therapy and provide the organ support in such patients. The fungal sepsis should be identified and managed aggressively, and multiple departmental collaboration is the key to success. Thank you.
Uh, so this was a really a rare kind of a patient who unfortunately suffered one after the another infectious complications. Where the surgery itself may not have played much role, except that her perioperative surgical profile may be a little bit disturbed because of that, and therefore probably she had uh, higher severity of each and every infection that one may face. As per the available data, if one were to see the reports of dengue in the post-operative period are related to the reports of dengue septic shock and hemorrhagic fever only. So whatever literature we have suggests that the dengue in the post-operative period really manifests in the severe form. Although this may be a little bit biased because the less severe forms may not be reported or may not even be picked up. But whatever we know that in the perioperative period, the dengue hemorrhagic shock does have a mortality of about 10%. and the morbidity definitely increases multifold to the tune of 60 to even 80%. The reason for presenting this patient is that it is only because of the multi-departmental collaboration that one can save such patients. Otherwise, it becomes difficult to manage the operative problems with these patients.